Hello everyone. Good morning. This is a continuation of the previous class, as you know. In the previous class, we covered the first two parts, the opening slides and the Ectropion checklist. And today, we are going to talk about the cases, quiz part, and the closing slides. But before we start with the cases, I'm going to repeat some of the slides with some refinement. So if you remember this slide, it is all about the etiology. Just a quick revision, we classified, according to the etiology, the ectropion into congenital, okay, that can affect the upper eyelid or the lower eyelid, and acquired causes like involutional, that only affects the lower eyelid, paralytic, only the lower eyelid, cicatricial, upper or lower eyelid, and mechanical, only the lower eyelid. All right? So I'm going to add some additional information. So in order to diagnose involutional, for example, the patient should be old. Okay, this is like essential point in the diagnosis. But there must be another thing. In order to diagnose a case as involutional ectropion, there must be another thing, which is the absence of signs of other disorders. So in order to diagnose a case as involutional ectropion, there must be no signs of paralytic or lower facial nerve palsy. There must be absence of any scar in the lower eyelid. There must be absence of a huge mass of the lower eyelid, okay? So remember, because we may have cicatricial or paralytic or mechanical ectropion in an old patient. So let's revise again. For involutional ectropion, in order to diagnose a case as pure or like only involutional ectropion, the patient should be an old patient. Number two, absence of the signs of other etiologies. All right. Another point here regarding paralytic. In the previous class, I said that paralytic ectropion equals lower motor neuron facial nerve palsy. But actually, there are other causes. And I think one of you said myasthenia gravis. So actually, myasthenia gravis can cause ectropion of the lower lid, and they call it afternoon ectropion, because it's not only the levator muscle that can be affected by the myasthenia, and we have ptosis, of course, you know this, but some patients may also have weakness of the orbicularis. So paralytic ectropion is all about weakness of the orbicularis. So weakness of the orbicularis by facial nerve palsy, because orbicularis muscle is supplied by the facial nerve, or maybe weakness of the orbicularis because of myasthenia, which is a disorder of neuromuscular junction, okay? Or maybe, as I said before, as a complication, one of the complications of Botox is ectropion of the lower eyelid. But of course, the most important cause for paralytic ectropion is the facial nerve palsy lower motor neuron, ipsilateral lower motor neuron lesion. All right. And I said before, don't forget that we may have mixed etiologies in one case. We may have a patient with involutional ectropion, and also there is a mechanical component or cicatricial component, as I said before. And I mentioned also we have iatrogenic causes of ectropion. Generally speaking, the lower eyelid is more affected by the misalignment, whether it's entropion or ectropion, because the lower eyelid is less developed than the upper lid. And in the viva, as you know, sometimes the examiner may give you a photo. So in cases of ectropion, usually the photo for ectropion, the image should be a little bit not restricted to the globe or the eyelid, the lower eyelid. There must be some skin. The photo should also expose the lower part of the skin, because in order to diagnose cicatricial ectropion, there must be scarring here or a mass here. That's why I wrote here, the extent of the photo in viva, it should be exposing significant amount of the skin below the lower eyelid. So before you decide what is the cause of ectropion, you have to check the skin, okay, below the lower eyelid in order to exclude any scarring. And sometimes if they are giving you a case of paralytic ectropion, usually the patient was instructed during taking the photo to close their eyes to show you the lag of thalamus caused by facial nerve palsy, like in this photo, okay? But regarding the iatrogenic ectropion, I said in the previous class, one of the causes is inappropriate closure of the eyelid wands. For example, there are something called tension lines. In the whole body, there are something called tension lines at the level of the skin because of the arrangement of collagen, all right? So the tension lines in the upper lid and lower eyelid are horizontally arranged. They are called the Langer's lines, by the way. But here in the medial canthus area, it's like vertical, and here in the lateral canthus area is horizontal. If there is a wound here, let's say in the lower eyelid, very close to the lid margin, if there is a wound here, we try to close it horizontally as much as we can, okay? In order to decrease the amount of scar and in order to decrease the incidence of cicatricial ectropy, okay? There are some additional details regarding how to close wounds near the lid margin, or if you are going to take a biopsy, like excisional biopsy for a tumor, how to fashion your biopsy, okay? Sometimes we make it horizontally, and if it is a little bit big, we can make it vertically in order to decrease the incidence of iatrogenic ectropy. And that's why if we have a case in the emergency department or the trauma department, and these patients have wounds near the lid margin, these cases should be managed or surgically repaired by, ideally by an oculoplastic surgeon, or maybe by ophthalmologist who has like special knowledge regarding how to repair wounds near the lid margin, and sometimes by plastic surgeon who are specializing in treating wounds near the eye, preocular area, okay? So we have to be carefully to prepare wounds near the lid margin in order to decrease the incidence of iatrogenic ectropion. Another cause for iatrogenic ectropion is excessive skin removal during lower lid blepharoplasty, like in this photo. This patient, according to the reference, had cicatricial ectropion, as you can see here, mainly in the lateral part here and here of the lower eyelid after facelift and lower eyelid blepharoplasty. And I said before how we can avoid such complication. So can one of you tell me how we can avoid such complications? Like how to avoid excessive skin removal during lower eyelid blepharoplasty?
We can ask the patient to look up and open the mouth.
Yes, yes, well done. Okay, thank you. Thank you so much. So stay with me, doctor, please. We have here another sign. So can you tell me the name of this stain? This stain, this greenish stain?
Lissamine stain, ma'am.
Excellent, excellent. By the way, it's called one of the vital stains. We have also fluorescein and rose bengal, okay? So why we call it vital stain? Why we call it vital? Do you know?
It's the living tissues.
Yes, exactly. So because we are staining a living, applying a stain on a living human body, okay? And we are examining this human or this living body on the slit lamp or anything. But generally speaking, we can use a stain on samples in pathology labs. These stains, like James stain and other stains, you know, there are a lot of stains. We can use it on samples in the lab. So they called it lissamine green and rose bengal and fluorescein vital stains because we stain a living body and examining living tissue. Thank you. Here the examiner is applying lissamine green, maybe to check the cornea, but there are another additional benefit for applying the stain in such a case. To show us what?
Pooling of the stain.
Yeah, yes. Pulling of the stain, because definitely the puncta here are not coapted to the globe. So it's kind of what we call this sign. We have epiphora, okay? So there is pulling of the stain. Thank you. So this is an example of how we can have like iatrogenic ectropion following lower eyelid blepharoplasty. And the mechanism of the ectropion is shortage of the anterior lamella of the skin. So it is somehow considered as a type of cicatricial ectropion. And this patient actually, according to the author, required a large supraclavicular skin graft. So this is actually one of the donor sites for skin graft, supraclavicular skin graft. So can anyone tell me other donor sites for skin graft?
Other eyelid or same upper eyelid.
Yes,
Postauricular skin
exactly.
and supraclavicular.
So post-auricular and pre-auricular. Okay,
Prior-
those-
Auricular.
thank you. Excellent. Thank you. And this is appearance of the patient. You can see this is like on the right side after 24 hours and on the left side after 1 month of the skin graft. Again, Botox. So if we are talking right now about the mechanism, so number one and number two, it is cicatricial ectropion. It's iatrogenic, but in between brackets, cicatricial. Number three, it is iatrogenic, but in between brackets, it's paralytic. And we also said post-entropion surgery, and somehow it is somehow desirable to have some mild ectropion in the early post-operative period. But sometimes it might persist. So as in this photo, this patient have a kind of ectropion medially, according to the author from this book, after entropion repair. And here, note the punctal and medial eyelid ectropion. So if you remember, sometime we said sometimes the ectropion is not generalized. It's only restricted to one part, usually in the medial part, especially if we are talking about involutional ectropion. So we need in the history to take a history of post-surgery. So this patient has ectropion post-entropion repair. Okay. If you notice here, there is a space here. Can we add a word here before ectropion? So if you see, I wrote ectropion here in a lowercase, like small letter. It's not the beginning of the sentence. Can we call the ectropion after entropion repair? Can you give it a name? Like,
Iatrogenic?
yeah,
Medial.
another, yeah, medial, it's written here, medial. Another synonym to post-entropion. When we have a complication opposite to the primary disorder, can we give it a name?
Consecutive.
Excellent, doctor. So it's like sometimes we get consecutive esotropia after exotropia surgery. Here, the same. In some reference, we may find this term, consecutive ectropion. So even without finishing the end of the sentence, once I say consecutive ectropion, that means it is after entropion surgery. Okay, so consecutive means the opposite of the primary disorder. This additional point actually is written in Kanski, but indirectly. If you remember, you will find in the surgical management of entropion, so entropion, you will find like a sentence in Kanski said, you need to address the lower lid laxity in order to have a satisfactory outcome and to avoid any complication. So if we are going to treat entropion, okay, but we didn't address lower lid laxity. So we have different surgeries for lower eyelid entropion. But if the patient had laxity, but we didn't address it in the surgery, okay, it may result in ectropion. And this ectropion will persist. Why? Because if you remember, lower lid laxity is a common pathogenesis in both involutional entropion and involutional ectropion. So once again, if you have a like involutional entropion, and you manage the case without addressing the horizontal lid laxity, despite the presence of significant laxity, the patient may change from entropion, like involutional entropion, to ectropion consecutively, and this will persist. And that's why we need to assess the lid laxity very meticulously. And if there is significant laxity, you have to do the surgery for that laxity. All right? I hope you got it.
Ma'am,
Yes.
to avoid the excessive skin removal, the point mentioned, I cannot understand that. The blepharoplasty, excessive skin removal during lower lid blepharoplasty. How to avoid that? What is the way? It's been mentioned. Can you explain that? Opening the mouth.
Okay, it was mentioned in the previous class, actually. Just imagine in your head right now, okay? If you look upward, so now look at upward, and you open your mouth and open your jaw, okay? This puts the skin of the lower eyelid on maximum stretch.
Yes, ma'am.
So the surgeon, the oculoplastic surgeon, should decide the amount of the skin to be removed at this point. Imagine now you are pinching by your thumb and your index finger some skin.
Yeah.
And imagine the alignment of the lower eyelid margin. You may feel this is an excess skin. But if you ask the patient to look up and open their mouth, by the same amount of the skin you pinched between your fingers, you may notice ectropion. So you have to decrease the amount of the skin to be removed. So let's repeat again. By these two instructions, we are making the skin under stretch. At this point, decide how much skin to be removed.
Yes.
Otherwise, you will end up with excessive removal of the skin and you may get this ectropion, which is a severe complication.
Okay, it is just wanted to assess the excess skin. We have to ask the patient to look up and open the mouth.
Yes.
At this stage, we have to assess how much skin to be removed. Okay, ma'am, got it.
So this is again the checklist that we discussed thoroughly in the previous class. I have to add some additional point here because you may find this in other references. In some references, the distraction test, it's called pinch test, okay? But in Kanensky, they are used synonymously. So pinch test is the distraction test when we pull the lower eyelid anteriorly. In some references, when you check the lateral canthal laxity, if you remember, we pull the lid medially. So it is called medial distraction test. And to check the medial canthal laxity, we pull the lower eyelid laterally, and it is called lateral distraction test. So please don't confuse these terms. Whenever you see a medial or lateral distraction test, now we are talking about canthal laxity, okay? But without mentioning anything like distraction, just distraction test, we mean here the pinch test. So this again, the distraction test, since there is no medial or lateral, so we mean here to pull the lower eyelid anteriorly. Ideally, you have to measure the amount of distraction, the amount of displacement here. And regarding the grading, I said the grading under the heading of involutional, but we can apply it, generally speaking, on any type. And I mentioned only 3 grades, okay, grade 1, 2, and 3. In some references, they subdivide the grade 1 into 2 grades. It is written in Wikipedia under the heading of cicatricial ectropion. So grade 1 is just punctal eversion, or just part of the posterior lid margin is not opposed to the globe. And grade 2, the whole length of the posterior lid margin is not opposed to the globe. And grade 3, as I mentioned before, the tarsal conjunctiva is visible, and grade 4, the fornix is visible. All right, so you can stick to this classification. The other one, it doesn't matter. Okay, so if you remember the pathogenesis of involutional ectropion, I said it's all about the laxity, horizontal lid laxity, medial canthal tendon laxity, and lateral canthal tendon laxity, plus the gravity. But there are some additional points, like what? In some books, you will find that, as I said before, laxity is a common pathogenesis in both involutional ectropion and involutional entropion. It is said that if the globe is well supported and large, laxity can result in ectropion. But if we have like small globe or like atrophia bulbi or bulbi, you may get involutional entropion. Okay, so globe size is an important support to the eyelid as well. So again, it is sometimes said that laxity with well-supported globe can result in involutional ectropion, but laxity with small globe can result in involutional entropion. But I think it's more complicated than that. And also lower lid retractors. Actually, lower lid retractors, dehiscence and disinsertion is some of the involutional changes. And we need to repair lower lid retractor disinsertion in involutional entropion. And sometimes we needed to do it the same in involutional ectropion. So again, this insertion of lower lid retractors may be an additional factor or in the pathogenesis of involutional ectropion. Okay, so I found this in the American Academy. The oculoplastic surgeon may address also the lower lid retractors repair in involutional ectropion. But the most important ones are the first three that are written in clinically. As you can see here, this is taken from American Academy. Repair of the lower eyelid retractors may occur in ectropion because we are talking about an old patient, especially if we have, like, you know, some cases of involutional ectropion is so severe and you have the whole lid is everted. We call it tarsal ectropion. And in the surgery, the surgeon should address also the reinsertion of the retractors plus tightening of the eyelid, horizontal tightening of the eyelid because there is laxity. So we can add assessment of lower lid retractors in the checklist. So if you remember how we can assess lower lid retractors, by the way, we mentioned it in the Ectropion checklist. Can any of you tell me how to check the lower lid retractors?
Assalamu alaikum.
Alex, salam.
We track the lower lid a little bit down, and then we ask the patient to look from straight. We'll ask the patient to look downwards. The fornix should come up as compared to the primary position if when the retractors are working fine.
All right, so your reference differs from mine. So you said something I'm not familiar with, but
We look for the excursion of the lower fornix when the patient looks down. This is what I.
So how do you assess? So if you remember, we have lower lid retractors, right? And we have upper lid retractors. What are the upper eyelid retractors?
Upper eyelid retractor is the Muller's muscle, and the lower eyelid retractors are the similar to molars, which arise from the inferior rectus and attach into the lower fornix.
So my question is, what are the upper eyelid retractors?
Molar PS.
Molars and
Molars
LPS.
and LPS.
Only molar?
Molars and LPS, levator.
Yeah, please don't say abbreviation, please.
Okay.
Say levator. Be respectful to the name of the muscle. It has three keywords, but it's enough to say levator. So levator, you have to start by levator. So levator, palpebral superiorus, and the molar muscle. Okay. So we have two upper eyelid retractors, and you have to start by the levator because this is the most significant one. So how to assess the levator function? You must have a ruler, okay, and you have like two positions. First, you have to abolish the action of the frontalis, okay, and to ask the patient to look from extreme down gaze to extreme up gaze. Of course, you know this. The same applies to how to assess the lower lid retractors. You must have a ruler, okay, and there's two positions, and you have to measure the excursion. So in the lower lid retractors, the excursion from the primary gaze to the down gaze. So can you repeat it again on how to assess the lower lid retractors?
We have to have a measuring scale, and we have to put the scale around the midline, in the midline along the inferior lid margin, and ask the patient from straight-eyed primary gaze to maximum down gaze.
Okay,
So
normally?
Normally, I don't remember. I think
So if you laugh at the exam, so the examiner will not give you extra marks for your smiling. So
Okay,
but
sorry.
it's good to smile and to laugh, but be careful.
Okay.
So normally,
I don't remember.
me either, but I think it's around 5 millimeters. Okay. So you have to go back to the Ectropion checklist and to revise how to assess the lower lid retractors. But again, this is like advanced. I think it's advanced in the miscellaneous point to mention lower lid retractors assessment in the Ectropion. Thank you. Regarding the fornix, I have no idea. You have to double check your reference.
Yes, ma'am. It's more of a surgical point, I think.
Maybe. It's written in the American Academy, but because I have no experience with this, practically speaking, It's written in American Academy, but differently, but not the same way as you said. Okay, thank you.
Thank you.
You're welcome. All right. So again, remember, assessment of the laxity is not only for involutional ectropion. You have to assess laxity regardless of the etiology. As I said before, in paralytic, cicatricial, and mechanical, laxity can be induced by the pathology. So by the paralysis, by the scarring, long-standing scarring, by long-standing mechanical mass. The process of laxity can be exaggerated and accelerated. So you have to assess the laxity in these cases, because the surgeon may need to address the laxity plus the surgery for cicatricial or mechanical or whatever. All right. So laxity is not only for involutional ectropion. And if you remember also, we have to assess laxity whenever we have a patient with watery eye. Okay. So whenever we have a patient with watery eye, you have to assess laxity because they may have subtle medial ectropion that may be evident after a snapback test, for example. I've shown you a case, my colleague's case, if you remember in the previous class. Okay, now the beginning of our class. Cases. Sometimes I bring some Viva questions related to the topic. The first question was about ectropion. The scenario starts with a photo. The examiner gives the candidate a photo of ectropion. And this experience was well written. And the candidate was very nice enough to bring also a similar photo in her experience. So this was in Delhi, 2 years back. I guess here the examiner asks the candidate to mention the types. So sometimes we say types, or sometimes we say causes of ectropion. Okay, but as you see here, I inserted a bomb sign because you have to listen carefully to the examiner. Are they asking about general question, like what are the causes of ectropion in general, or are they asking about the cause of ectropion of such a patient demonstrated in the photo? Okay, again, you have to listen carefully to the examiner's question. Is the examiner asking like a general question, tell me the cause of ectropion in general, or tell me the cause of ectropion of this case? So now imagine the examiner asked the candidate to mention the types or the causes in general. I need someone to volunteer. This experience is very easy. Someone who watched the previous class.
Congenital and acquired, ma'am.
Yes.
Under acquired, we have involutional, paralytic, cicatricial, mechanical, and iatrogenic.
Okay. So here's the candidate. Actually, in her experience, she missed paralytic, and she didn't mention congenital. But it's okay. Maybe she mentioned it in the exam, but she didn't write it in her experience. So that's why I always say, don't study from the experience. Candidate's experience is not a study material. It's something that guide you, that show you some questions, because some experience, they are not 100% accurate. They are not comprehensive. Okay. Again, don't study from the experience, but use the experience as a guide to know the questions and to know the scenarios. So what is the cause of involutional? Here, the examiner was asking about the pathogenesis. So for those who skip some headings, no, don't skip some headings. Some candidates may skip basic information because they may think, who cares about the pathogenesis? This is like something like basic. So please don't skip. It's important because, as I said before, the pathogenesis is important because each point in the pathogenesis is going to be assessed clinically and addressed surgically. So you have to know the points of the pathogenesis for involutional ectropion. So what are the points of the pathogenesis? Quickly.
Horizontal lid laxity, medial canthal tendon laxity, lateral canthal tendon laxity.
So here the candidate just mentioned laxity as a key point. All right, excellent. Here the examiner asked about the SNS, I guess, sign and symptoms. Just tell me the symptoms. What could be the symptoms?
watering and foreign body sensation.
Yeah. Let's see what she said. Foreign body sensations, watering. Okay, but actually, because this is about symptoms and signs, she mentioned as a sign inferior corneal ulcer. What she wrote inferior?
She probably meant exposure keratopathy.
Yeah, which is mainly inferior. Thank you. And here's the management. Let's say surgical management or surgical treatment. What is the surgery on such patient? Now the question is restricted to the patient. Suppose this is an involutional ectropion. So what is the surgery for involutional ectropion?
Lateral tarsal strip.
So according to the assessment, but don't forget lateral tarsal strip, which is commonly used. So she said here, or she wrote lateral tarsal strip and lid shortening. Actually, lateral tarsal strip is one of the surgeries for lid shortening. There are another surgery for lid shortening, but the most important one is lateral tarsal strip. Again, lid shortening is a broader, like a big heading. Under this heading, you will find lateral tarsal strip. Okay, now the examiner switched to another question about the seventh nerve palsy. In the management of seventh nerve palsy, so this is a general rule for any palsy, even in strabismus, we need to observe, okay? First, you need to know the etiology. This is very important. And you need to observe for 4 months or 6 months in the hope of spontaneous resolution. So don't forget the observation, okay? So let's see. If we have like a Bell's palsy, are we going to observe the patient, like allow the patient to go home without any medications, or during this observation period, we give something to the patient?
We give lubricant and ask the patient to tap the eye during sleep.
So generally speaking, this could be measures to protect the cornea. You need to protect the cornea, okay? So will epiphora resolve surgically if they have a surgery, like persistent paralytic ectropion, and you're going to do a surgery for paralytic ectropion? Will the epiphora completely resolve? We have different mechanisms for epiphora in ectropion, okay? Yeah. The most important one, the punctum is malpositioned, is ectroponized. Now we surgically corrected the position of the punctum. Do you think the patient will still some epiphora?
Yes, ma'am.
Yes, because of?
Lacrimal pump
Yeah, because we can't do anything for the lacrimal pump failure, okay? We have to protect the cornea, lubricant stepping, maybe tarsorrhaphy, this is an important line. Also, we may inject Botox in the upper eyelid to induce ptosis, okay? So the temporary measures mentioned in Kanisky are very important, okay? Don't skip it.
Madam, I have a question here.
Yes.
Why could this not be involutional ectropion? No, I'm talking about this picture. Could this be an involutional ectropion?
Why it is involutional?
No, I'm just asking, why could it not be an involutional ectropion?
So
Why
repeat
paralytic?
Not paralytic? Okay, we don't know. So I guess this is a differential diagnosis, but you have to start by involutional. If you are going to give the examiner a list, okay? So suppose the examiner now was asking me about the cause on such a case. Okay, so I may say the patient looks old, so I suspect involutional ectropion. But in order to diagnose, as I said at the beginning, in order to diagnose involutional, the patient is old, but there must be absence of the signs of other disorders. So I need to check orbicularis, check the lag of thalamus, check for the other signs of lower facial nerve palsy. If there is no other signs of facial nerve palsy, and I guess there is no scar and there is no mass here, this is definitely involutional, okay? So I said before, there's a kind of discussion. But if the examiner cut you off and told you there is lag of thalamus, the patient can't close their eyes, probably. But again, if you notice here, the eyebrow for me, there is no drooping, because drooping of the eyebrow is one of the signs of facial nerve palsy. So this is probably not a facial nerve palsy, not a paralytic ectropion. This is involutional. So despite there is no instruction to the patient on the photo to close their eyes, I can predict this is not a facial nerve palsy because the eyebrow is not drooped. One of the signs of facial nerve palsy is drooping of the eyebrow. okay? And sometimes there is also pseudotosis. But I said before, temporary measures are not only for paralytic ectropion. In any kind of ectropion, you have to check lag of thalamus and the cornea and the Bell's phenomena, of course. So sometimes we have severe ectropion regardless of the etiology. And in severe ectropion, you may expect lag of thalamus, okay? So you have to do the temporary measures while awaiting for the surgery. Because in Kanetsky, temporary measures were mentioned only in paralytic. But some of the lines of temporary measures can be applied also to involutional and other etiologies.
Ma'am,
Mm-hmm.
I have a question.
Yes.
I read some points of this in Oxford. There is one line mentioned like that: if there is a horizontal lid laxity without any lateral or medial tendon laxity, wedge excision may be the option. Wedge excision.
Not lateral tarsal strip.
No, yes. They are saying that in Oxford. Actually, I can't get the message of that line. They're saying that if there is only horizontal lid laxity, no lateral or medial canthal laxity, only wedge excision is sufficient.
Okay, so wedge excision or lateral tarsal strip, both are under the heading of lid shortening, eyelid shortening surgeries. So wedge excision, actually it is mentioned in Kanetsky under another name, Pentagon excision, okay?
Yes.
So this is a bit of details on how to choose which one to choose, lateral tarsal strip or Pentagon excision, okay? So, but good to know. Thank you.
I don't know actually what is the message for this line. Okay, ma'am. In exam, we will tell LTS, no?
If you want to cover everything, you can say in excessive lid laxity, we have to do eyelid shortening, like lateral tarsal strip or Pentagon excision.
Yes, ma'am. Yes, ma'am.
Okay.
Got it.
But
Thank
I
you.
think it's written in Kanetsky, if there is, for example, so I'm not talking about the surgery. This is not a comprehensive class about the ectropion. But anyhow, if we have like a medial lateral cancer laxity, and you are going to do lateral tarsal strip, there will be much displacement of the punctum medially. So again, if we have much medial cancer laxity, there is a specific surgery for medial cancer laxity. So if you ignore the medial cancer laxity and did only lateral tarsal strip, the punctum here will be very much displaced laterally, and this is not satisfactory outcome. There is some more details regarding which surgery to choose according to your assessment.
Yes, ma'am.
Another question in Amman, again here in the eyelid and oculoplasty station, I think the candidate was given a photo. Sorry for the spelling mistakes, just copy paste the experience, like print screen. So here the candidate mentioned severe ectropion, not severe ectropion, and the examiner asked about the description. Sometimes you may start your answer by describing the photo. Again, another question about the causes and how to manage. I guess here it's about the surgical management. But again, don't forget that you need to mention the temporary measures or non-surgical measures at first. And here I wrote additional points because you need to mention the side. If you remember, we need to say on the right side or the left side, is it upper lid or lower lid? Because it's going to help you in the etiology, in reaching the diagnosis, the etiological diagnosis. And this is from Mumbai, 2 years back. So here, can you read this experience? Read it out loud.
Anterior segment photo of a patient with cicatricial ectropion. When would you treat?
So I think how, not when. But anyhow, so do you have any comment about the way of writing here? Is there any improper word choice?
Anterior segment photo of a patient.
Yeah. What's the meaning of anterior segment photo? Usually we say this word or this description on what?
The conjunctiva, cornea.
Yeah, usually, yeah, when we are examining the anterior segment by slit lamp, usually it is a photo taken by the slit lamp or, but this is usually the photo for ectropion and entropion are external photo. So this is not an anterior segment photo, okay? And what do you think? The candidate must have seen what scarring in order to diagnose ectropion. So
Yes.
how would you treat cicatricial ectropion?
That,
Again, I am not an oculoplastic surgeon, so your information should be better than mine because you are the one who are currently studying and the one who are sitting for the exam.
oh, okay, ma'am. And ma'am, the candidate doesn't mention this which lead and which eye. We have to mention that also.
Yeah.
And in treatment, first I have to assess. First, in inspection, I am seeing the scar. That's why it is cicatricial. And along with that, I have to assess the lead laxity present or not. Then I will go for first conservative treatment like lubricant.
Okay.
Sometimes
Mention the surgery.
Yeah, surgery is if there is focal scar, I will go for Z plasty. If the scars is bigger, then I will go for skin grafting. And there's something other, ma'am, I have forgotten.
Okay. Any additional answer?
Mid-face lift is one of the given in Oxford. Mid-face lift for.
Oh, yeah. Okay, this is something more advanced. We need a plastic surgeon as well. And if there is laxity, and good that you mentioned laxity, so you have to address laxity in the surgery as well. Okay.
Yes.
Thank you. So stay with me. In continuation to this experience, the examiner pointed to the punctum and asked if there is an issue over there.
There might be, ma'am, medial ectropion that might lead to the everted inner punctum.
Okay, so this one possibility. Is there another possibility?
Stenosis, punctum stenosis.
Yeah, stenosis. So we have something called secondary punctum stenosis. So whenever we have ectropion, one of the secondary changes is stenosis of the punctum. So, and if there is severe stenosis, what shall we do? Actually, there is a couple of papers about this. Sometimes the surgeon may also do 3-snip punctoplasty. So this paper is about adding this procedure to the management in order to address punctal stenosis, secondary punctal stenosis. Okay?
Yes, ma'am.
And I think we said this in the previous class about the punctum stenosis. You have to, in the checklist even, you have to check the punctum. So please don't forget the punctum. So this is from Kanisky, the paragraph, but it is in the lacrimal chapter. So here, ectropion, either localized to the punctal region or involving the whole eyelid, is often, so see, it's often, so it's not rare, it's often associated with secondary stenosis. All right, so I checked a couple of experience like recent over the last 3 years, and I haven't found any experience about cases of ectropion in OSCE. So instead, I'm going to share with you some material that may be helpful to you OSCE-wise. So I'm going to show you my colleague's case. I need someone to volunteer, especially those who are going to sit for the exam, I think this month.
Yes, ma'am.
So I'm going to ask you while we are watching the video, okay?
Yes, ma'am.
So first of all, what is this black bar? Is it a glitch in creating the video or something intentionally placed?
It's intentionally put
Why?
to cover the nasolabial fold and half of the face of the patient.
So do you think that we are applying this to hide signs? No, not to hide signs.
To hide the identity of the patient.
To hide the identity. Why it's important to hide the patient's identity? Because imagine my colleagues is video recording the patient. So definitely he had taken the consent from the patient to be video recorded.
Maybe it is to respect the privacy of the patient. Don't know exactly.
Yeah, because generally the consent is all about recording, but not publishing on YouTube. So it needs another detailed consent, because if you are going to publish a photo for your patients or a video on social media, you have to take a detailed consent for this.
Okay.
Thank you. In order to camouflage the patient or to hide its identity, you have to crop the video like to a greater extent. But here you can see the forehead, you can see the mouth. So why I didn't crop the upper part and lower part and just restrict the view to the eyes? Because they have signs, okay? They have signs. So I
Yes,
didn't
ma'am.
crop this area and this area because they have signs, okay?
Yes, ma'am.
So by inspection, can you tell me what do you think? What are the signs by inspection in this young man?
Yes, ma'am. On the right side, the forehead wrinkles are absent. In the right eye, there is a inferior scleral show. There's a bit of watering and mild ectropion, and there is a drooping of the right facial corner of the mouth. Here, right lower motor neuron facial nerve palsy.
Yeah, exactly. You got all the signs, and they are like a single diagnosis. This is a case of lower facial nerve palsy. What is the most common cause of lower facial neuron palsy?
Bell's palsy is the most common cause.
So what is the etiology of Bell's palsy?
Is idiopathic
Yeah,
facial nerve
exactly.
palsy.
Idiopathic. But in order to diagnose it, you have to exclude other causes. Exactly.
Yes, ma'am.
So this is a practice for inspection.
I just have one comment regarding the signs you mentioned. Ectropion is not visible at that distance, so I can't say there is ectropion. I guess you said it because you think it should be ectropion in facial nerve palsy, but what's obviously visible that there is inferior scleral show, and you can say there is lower eyelid retraction, because lower eyelid retraction is one of the signs of facial nerve palsy. Okay, if you remember, facial nerve supplies orbicularis, which is the muscle responsible for closure of the eyelids. So it elevates the lower eyelid. Okay, and what is the opposing muscles for orbicularis is lower lid detractors. What is the function of lower lid detractors? They depress the lower eyelid. So if we have orbicularis weakness, like palsy, facial nerve palsy, so we have defect in the orbicularis action, which is responsible for elevation of the lower eyelid, and the antagonist, the lower lid detractors, is still acting, so they depress the lower eyelid. So because of weakness of orbicularis and overaction of retractors, okay, we get lower eyelid retraction with inferior scleral show. So instead of saying ectropion, you can say inferior scleral show, most probably due to lower lid retraction.
Now, what is the sign?
In the right eye, there is a lag of thalamus, and the cornea is fully gone in the disappears in the upper lid. It's good Bell's on the right side.
So positive or, yeah, excellent Bell's phenomenon. Exactly. Okay, so this is very supportive to your diagnosis. Okay.
Yes, ma'am.
What's this test? Name this test.
This is the snapback test.
Yes. So name this test.
This is the test for checking the medial canthal laxity.
Okay, so if you imagine the punctum, it's like here, it's maybe here. Now compare it with the left side. Okay, so even by comparison, without any measurements, you can appreciate that definitely there is some laxity or flaccidity on the right side, on the paralytic side. And if you remember, in the previous class, whenever we have a long-standing paralysis, there might be some sort of laxity.
Yes.
Okay, this is the distraction test. Okay. All right, so I think the cases of Bell's palsy are not rare. So you can see a lot of cases, especially if you attend a neurology clinic. So you can do the steps for ectropion evaluation on these patients. So it's not hard to find a case with paralytic ectropion. I can say they are, I'm not sure, but they are common. They are not rare.
Yes, ma'am.
Actually, this patient underwent surgery. So the next video, I'm showing the patient, I think 1 week post-operative, because this is not my case. I'm not practicing oculoplasty, but anyhow, so I want you to guess what surgeries have he had based on the scars, or let's say based on the wounds.
I can see a scar on the around the lateral canthus, so it is most probably a lateral tarsal strip with a canthoplasty, lateral canthoplasty.
Before we start, I want you to comment on the eyelid position.
The right eye upper eyelid is slightly ptotic as compared to the left eye. Is it because of postoperative edema or?
Yeah, it might be because of postoperative edema. We have some sort of mechanical ptosis. And as you can see, this is actually a retraction, but we call it what? We call this retraction what? Contralid retraction as a compensatory mechanism. Because whenever, because if it's ptosis, the patient is trying to elevate the eyelid. And because of Hering's law, there will be contralateral lid retraction. But if you manually elevate this eyelid, this static eyelid, this lid retraction will be corrected. All right. So you give me one explanation for this ptosis. Do you have other explanation for ptosis in this setting?
They could have used gold weight or platinum for the upper lid.
Okay. So in order to discriminate, you have to check for the skin, if there is any wound in the upper lid skin or not. Let's see. So here, there is a wound here. So actually, this patient underwent gold weight implantation in order to treat what?
In order to treat the lack of thalamus, because
and you can
of
see the lack of thalamus is improved to a greater extent. There is a small rim here, but compared to the preoperative, it is almost improved. Okay, so my question, because I know you haven't seen or you haven't attended my previous classes, but in order to check lag of thalamus, sometimes the patient has lag of thalamus that's very subtle. Okay, sometimes we may instruct the patient or do a maneuver in order to diagnose subtle lag of thalamus. This is a general question.
Yes, ma'am. We ask the patient to extend the neck and gently close the eye.
Yeah, and so you ask the patient to extend their neck and gently close their eyes. And regarding you look from down, like worm's view. Okay?
Yes.
Exactly. In order to detect the subtle lag of thalamus, because it might not visible here because of the eyelashes, but if you extend the neck and you are looking from below, you are like as in worm's view in proptosis evaluation, you may find some subtle lag of thalamus. So this patient actually underwent 2 surgeries, the gold weight here and the lateral tarsal strip, because of the laxity. According to my colleagues, the patient also has signs of exposure keratopathy, and the patient was referred from the cornea specialist to address the eyelid in order to ensure the health of the cornea. Thank you so much. You did very well. Excellent.
Thank you, ma'am.
You're welcome. I need another one to volunteer. The next one and the last one in the OSCE is a lot of fun, because it's going to be a role play between a candidate and the examiner. And I'm going to play the role of the poor candidate, and you will plays a role of the examiner. I made this story up in order to allow you to practice a little bit to feel the vibe of the exam. So who is going to volunteer?
I will do, ma'am.
So I'm just wondering about the rest. Okay. So you can listen to the recorded video. But by the way, the recorded video is much better than the live one in terms of yeah, it's I remove the pauses and unnecessary parts. Sometimes I remove mistakes. So if you are going to listen, I recommend to watch the recorded version. But don't miss this opportunity to participate. Okay? We'll see. Again, I made this story up, and I'm sorry, this is a sad story. We have sad ending because the candidate was going to fail the station or to fail the case. He will get a fail mark in the case. Why is that? Because sometimes we humans conditioned that negative experiences have more impact on us, will shape us more happy endings, okay? So what doesn't kill you makes you stronger, as they say. So maybe if you dramatize the case, you will grasp this information better, hopefully. So are you ready?
Yes, ma'am.
All right. So imagine now you are at the oculoplastic station. Okay, so I am the candidate. Remember, I am the candidate, and I was given a patient like this one.
Okay.
You are going to just read what is written. So your role is just to read what is written on the slide. So here is the examiner. You are playing this role, the examiner. So you will say, examine. My response is not written in the slide because I want you to be attentive to my response. By the way, I am playing a role of a candidate who has a decent knowledge, but I'm not that competent, okay? I prepared for the exam. I did my best, but somehow I didn't get the sign, the most important sign. I didn't pick it, and I'm not competent at some stages, and that's why I failed the exam, okay? Sometimes not all the candidates who failed are not knowledgeable, but sometimes it's just luck, okay? So let's start. Say examine.
Examine, please.
Okay, sir. By inspection, I notice an apparent proptosis on the left side here.
How did you know?
Because the palpebral fissure here is wider, and one of the indirect signs of proptosis is we have a higher vertical fissure. But of course, I need to do Navziger view or Worm's view to confirm.
Then do it.
Okay, I'm doing it now. And then I said, okay, I did Navziger and Worm's view, but they are not conclusive. I can't decide. So in order to confirm the presence of or absence of proptosis, I need to do measurements by a ruler or by exophthalmometer.
Okay, here is the hurdle. Then now you measure.
Okay. Okay, sir, I know the technique for hurdle, but I'm not that familiar, but I will do my best. So right now, I'm doing hurdle measurement. So, you know, I need to do the measurement on both sides. And because I'm not familiar with the hurdle, I'm spending many minutes in order to measure. Okay. And then I found okay, sir, by measurements, this is actually a pseudoproptosis because measurements on both sides are within normal range.
What is your finding?
Okay, since there is no proptosis, but they have a wider fissure, I would say there is a retraction of the lower eyelid.
Okay, so what is your final diagnosis?
Now, for me, I'm not familiar with the causes of lid retraction. The only cause for retraction is thyroid, but this doesn't look like thyroid because there is no proptosis, there is no retraction of the upper eyelid. And also, this is not a facial because we don't expect facial in oculoplastics, but sometimes it happens. So for me, I paused after the examiner mentioned this. What is your diagnosis? I paused. Okay, I give the examiner a long pause.
So this patient presenting with a history of watering.
Okay, sir. The watering maybe because of the corneal affection. Maybe the patient have some insult to the cornea because of the lid retraction. So as you can see, I am narrow-minded at lid retraction. Okay.
But the eye is very quiet.
Okay. Yes, I can see his eye is quiet. Then the candidate is giving another long pause.
So what is that color that you see?
So as you can see here, the candidate didn't, we imagine that we have a case like this one. So the candidate should mention the staining at the beginning, okay? Here is the candidate. Yeah, this is fluorescein staining. There is fluorescein staining that was applied, instilled on the patient's eye.
Why was it instilled?
So here the candidate said to check the cornea. So if you see, the scenario is all about lid retraction and cornea, and that's it. Okay. So because of the time spent in Hertel measurements, do you think the examiner was malignant? No, actually, the examiner was giving a candidate a clue. So first, the history of watery eye. Yeah, fluorescein is used to check the cornea. This is completely fine. But as you can see, if we have corneal affection, there might be some blepharospasm, some redness, some photophobia. Actually, the fluorescein here is used to show the candidate there is some pooling and there is even overflow of the stained tear film over the cheeks. Here there is a clue about the epiphyra, okay? And the examiner was repeating the clue by saying why it was instilled, but the candidate mentioned the same point regarding the cornea. So actually, the candidate missed an important sign, which is the punctum. You know, if you imagine that the candidate had come closer, he would have seen that there is subtle ectropion of the medial part and with punctum ectropion. Okay. But we don't expect cases like this in the exam. To be fair, usually they bring you patients with obvious signs. This is a case of involutional early ectropion. Because of the laxity, the lower lid is hanging down. Okay. Yeah, we can say it's a distraction, but the most important one not to miss is there is a punctum eversion. So you have to come closer to the patient. And if you remember the first class on this series, on the mock clinical practice, I mentioned this advice that you have to come closer. Sometimes you have to come closer to the patient in order to pick signs, because the punctum may have other signs like tube, or maybe have like punctoplasty, or maybe the punctum is absent, or there is stenosis, or maybe cheese wiring of the punctum because of the previous intubation. Maybe there is a scar here of DCR. Sometimes you have to come closer. Some candidates actually missed ectropion and entropion because eyelid alignment as a topic is not inside their minds. That was the role play. The role play ended sadly. Sorry about that. Okay, so don't forget punctum, punctum, punctum. There are many signs that can be present in the punctum. Again, from this reference, it shows you a pooling of the dye or the stain because of subtle punctal ectropion. So in front of you, you may not appreciate this is like grade 1 or grade 2 ectropion. There is a gap here between the lid margin, the posterior margin, and the globe. But applying the fluorescein, or here is the lissamine green, and this pooling, okay, will make the sign more obvious. And if you check the patient on the slit lamp or on profile view, you may appreciate the ectropion of the punctum. Okay, so, here, if you notice at the bottom of the slide, I wrote some abbreviation here. So personally, I don't like abbreviation, by the way, but I wrote abbreviation here in order to ask you about these abbreviations. So do you know these abbreviations?
fluorescent dye disappearance test versus fluorescent clearance test.
Okay, so tell me the difference.
So fluorescent dye disappearance test, we check to differentiate between hyperlactination and drainage failure, while fluorescent clearance test is done in dry eye, where after installation of 5 microliters of fluorescein, we will check in how much time within 15 minutes the fluorescein is getting cleared or not.
So somehow they are confusing because in both we apply a stain. It could be fluorescein or any stain, but the interpretation is different. So one for epophora or for defective drainage and the other one for dryness. If we are going to choose one for this photo, what would you choose?
So 1% or 2% fluorescent dye disappearance test would be a better option here.
Yes, so definitely there is a delay in the disappearance of the dye because of epophora caused by ectropion of the punctum. Thank you so much. The next part, the fun part, is the quizzes part. And I hope others please participate because some of the questions are all about thinking, your thinking skills more than your knowledge. You will find at least 10 quizzes. The aim, as I said a few minutes back, that it's a test for your thinking, okay? The ability to think clearly, okay, and calmly. And I hope you are a little bit stressed right now, hopefully, in order to practice how you can think and how you can answer under stress. And that's why I encourage all of you to participate. It doesn't necessarily to give a correct answer. We all do mistakes. We are here to share information and to correct our mistakes. So the meaning of think on your feet is to think under stress, okay? The ability to answer, even if it is the first time to come across this kind of question. Otherwise, if you don't practice this, you may sink in the exam, okay? In the previous sports, sometimes we allow others to cooperate, but in the quiz part, whenever I assign someone to answer or someone volunteer to answer, please others mute yourself and don't speak. We have something called the CCC, so it's not capsulorhexis, it's another thing. It's not continuous curvilinear capsulorhexis, it's about C for choices, chances, and changes. Now you have the chance, okay, to make a choice to participate. So please take this a chance, this opportunity to participate, because during the exam, you don't have such a luxury of choices. You will given the question and you have to answer it. Hopefully, by participation, there might be some change in your level of knowledge towards a better way, like towards excellence, hopefully. So remember, choices, chances, and change. In order to make a change, you have to take chances. All right, so the ball is in your court and you have to participate. And I have many questions, so all of you can participate, actually. Again, the questions are like a bizarre or bizarre. So we have a variation in the theme of each question. Some of them are very simple and easy and sometimes silly, and others are very difficult and challenging. Bear with me and try to have fun to explore the benefits of each question. The first question here is under the theme of Kandinsky's excerpts or snippets. So I have taken a paragraph from Kandinsky and I centered my question on this paragraph, okay? Let's see. This is a paragraph and you will find the word ectropion here under the heading of eyelid complications, okay? So my question is, from which topic this paragraph was taken?
Atopic keratotic conjunctivitis.
Atrophy? No. Try to think of another, because sometimes you may say to examiners something is like incorrect, and the examiner will say no. So you have to think about another answer. Atrophy is somehow reasonable, but it is not atrophy, okay? So think of another cause.
Any psychiatrical clauses, like chemical injury?
Are you currently studying from Kanetsky?
Yes, ma'am. Yes, ma'am.
Okay. So, no, this is not chemical burn. Again, it's reasonable, but it's not this topic. So, you know, in exam, it is time bound. Okay, so I will show you the answer. Okay, so it's Stevens-Johnson syndrome. Stevens-Johnson syndrome, as you can see here, it has signs on the conjunctiva. So there is affection of the conjunctiva and can result in cicatricial entropion. And also there is skin signs and scarring at the level of the skin. So it can also result in cicatricial ectropy. Okay. So again, you have to study Stevens-Johnson very well. Okay, stay with me. I haven't finished you yet. We have some disorders, okay? And I mentioned them in the previous class that can result in both entropion and ectropion, can result in both. Stevens-Johnson was one, we just mentioned it, but you have other disorders. And actually you mentioned chemical burn, so I will write chemical burn. So all disorders that can result in both are cicatricial in origin, okay? The mechanism is cicatricial. So if we have a chemical burn that affects the skin, it can result in cicatricial ectropion. If it is at the level of the conjunctiva, the tarsal conjunctiva, it can result in cicatricial entropion. So what are other disorders? And that's why I always advise you to take notes, because you are following my classes.
Involution. Involutional is
Yeah, involutional, but I'm talking about disorders like diseases like cicatricial that result in cicatricial. Yeah, we have involutional entropion, ectropion, we have congenital entropion, ectropion, okay? But I'm talking about disease that can result in scarring. The scarring could be conjunctival side or skin side, and that's why they can result in both ectropion or entropion, cicatricial. We mentioned trauma like chemical burn and Stevens-Johnson also. So if you remember herpes zoster, we'll mention the winner at the end of the quiz part. Thank you for your participation. I hope you learned something. But we have other disorder, and actually it was in one of experiences. This skin disorder. Do you know this skin disorder? So this is a question for all.
Oh, yes, this is xeroderma pigmentosum.
Xeroderma pigmentosum.
Exactly.
This is xeroderma
So
pigmentosum.
if you are given a case like this in the exam and you are describing the case morphologically, there is pigmentation, there is ulceration, you mentioned everything in a descriptive way, but you didn't mention the term. I don't know, but I think you will not giving the pass mark, because this is an important syndrome and it has pathognomonic features and you have to know it. So this is a xeroderma pigmentosa. So you have to know it and to know all the manifestations that relate to ophthalmology. Especially this is one of the important risk factors for what?
Basal cell carcinoma,
Basal cell
skin
carcinoma.
cancers.
Yeah, skin tumors in general, but basal cell carcinoma because this is the most common skin malignancy. And this is a very important topic. So you will find this is the #1 risk factor, syndromatic risk factors for basal cell carcinoma. And there is a nice paper here about the xeroderma pigmentosa, like a case series. And they found that 25% of cases had ectropion, cicatricial ectropion, because there is skin affection. So the skin affection in this series was more common than mucus or conjunctival affection. So you will find ectropion in 25% of cases and cicatricial entropion in only 2%. So xeroderma pigmentosa is one of the causes or the disorders that can result in ectropion and entropion, cicatricial in origin. And you can see also lagophthalmos, blepharitis, other eyelid manifestations. Okay. So I brought this rare syndrome because it was a case in OSCE in one experience. And again, I have shown you this slide before about herpes zoster ophthalmicus, about the late signs, the chronic eye disease sign. You will find here ectropion, cicatricial of course, and entropion. So remember, when I asked, do you know an infectious cause that can result in both entropion and ectropion? And we mentioned herpes zoster. Okay, so in continuation to the same theme of paragraphs taken from Kanetsky, here ectropion was mentioned, and this paragraph actually from dry eye chapter. So one of the basic lines for treatment of dry eye is to address any eyelid abnormalities. So you have to do reparative eyelid surgery if the patient has entropion or ectropion. And if you remember, if we have ectropion, the symptoms of dry eye will be exaggerated. So ectropion is important. And this paragraph was taken from the keratoplasty chapter. So one of the prognostic factors that adversely affect the prognosis of the corneal graft if the patient has ectropion. So before keratoplasty, you have to address any eyelid abnormalities like blepharitis, ectropion, in order to increase the success of your graft, the success of your surgery. So ectropion is important. Again, this paragraph was taken from the preoperative assessment before cataract surgery. Any disorder in the ocular adnexia, especially zacrocystitis, blepharitis, also ectropion, lag of sun, should be addressed before cataract surgery, because generally speaking, cataract surgery is an elective surgery. Yeah, there is some urgent indication for cataract surgery like phacomorphic or but generally speaking, cataract surgery is elective surgery. You have to address any abnormality in the ocular adnexia because it might increase the risk of what? Of endophthalmitis. So again, ectropion is important sign and disorder. Okay, now I finished the first theme. I'm giving you a half mark and got 0.5 mark. So the next question, I need another volunteer. There will be a winner at the end, but there is no any gifts. Okay. The gift is the learning experience. The next theme is about shapes and ectropion. So what is the shape of this building and how can you relate this shape to ectropion?
Yeah, it's a pentagon shaped building.
What's the meaning of pentagon, by the way?
It's a shape that has 5 sides.
Okay, excellent. So if we invert this one, it reminds us of what? Of this eyelid surgery that we may use in ectropion. Of course, this surgery has other indications other than ectropion. Like if we have a mass here, usually if I have a tumor here, we remove it in this shape. So this is actually correct. So excellent. I'm giving you 0.5 mark because it was an easy one. And someone answered it before you, but anyhow. So one of the shortening surgery, eyelid surgeries that we may use in ectropion with excess laxity is pentagon excision. Okay, excellent. And we have another shape here. What is the name of this shape and how can you relate this shape to ectropion surgery?
This is a
Again, it's related to one of the ectropion surgeries.
okay. It is a spindle shape.
Excellent, excellent. Well done. So, what's the name of surgery?
Yeah, it is a medial conjunctivoplasty spindle shape.
Perfect.
C
well
shape.
done. And it's indicated in cases with
the punctal eversion.
Yeah, punctal ectropion or punctal eversion. It might be used alone if there is only punctal eversion or maybe combined with other surgeries. So if you notice here, there is, what is this instrument? What we call this instrument?
This is a probe, lacrimal probe.
Lacrimal probe. Why the surgeon is inserted lacrimal probe in the lower canaliculus here? Why?
During the surgery, it is inserted to prevent injury to the canaliculus.
Yes, exactly. To protect the canaliculus because the excision is very close to the canaliculus. So what are the tissues? What are the tissues that are removed in this surgery?
It is the conjunctiva and subconjunctiva.
What are the tissues? Subconjunctiva, what we call it here. So if you see the sagittal diagram here,
Yes, ma'am.
according to the anatomy in this area, in this lacrimal part of this is called the lacrimal part of the eyelid. We don't have tarsus here, okay? So normally the structure behind the conjunctiva is the tarsus, but in this area. But what is the structure behind the conjunctiva or subconjunctiva in this area is the lower eyelid retractors. conjunctiva and lower detractors are removed in this area, in the spindle shape. Plus, there is also sutures. So there is also the surgery is not only about excision, but also the inverted sutures are placed. All right. Thank you so much. You got 1 mark total.
Thank you, ma'am.
Okay. The next theme is about photo and ectropion. So I'm going to show you a photo, okay, and you have to relate this photo to ectropion.
So watering.
Yeah, overflow of tears over the
Overflow of
tears.
tears.
But the man here is holding what?
Handkerchief.
Yeah, okay, I like this word. So is holding a tissue, okay. So how can you relate?
So in ectropion, there might be watering in case of medial ectropion or medial punctal eversion.
Can you give it a specific term?
Punctal ectropion.
So
Medial punctal ectropion.
instead of saying watery, can we say another word? We can classify watery eye into 2 big categories, remember?
Yes, ma'am.
Mm-hmm.
Okay. Got it.
Mm-hmm.
It is what I say. Not overflow. It is what is the term?
Okay. So you are quite relaxed right now, I guess. This is the aim of this quiz, is to think. Now you are thinking, you are trying to memorize information, and this is good practice, by the way. Okay. So you may feel this information is easy, but you have difficulty in recalling. So this is a chance to practice recalling information.
Yes, ma'am.
Okay, because watery eye is easy because this is something said by the patient. This is non-medical term, actually, watery eye. But in ophthalmology, we classified this layperson language into 2 categories. Excess formation has a name, and defect in drainage has a name.
Yes.
Which one is epiphora and which one is lacrimation?
It is, ma'am, epiphora. There is obstruction in the drainage, and an over secretion is
Over-secretion is lacrimation. So actually, in ectropion in general, we have many mechanisms for watery eye. Some related to epiphora and some related to lacrimation. And we discussed this at length in the previous class. But the most important one is to say epiphora. This is like a key word here. And we mentioned
epiphora.
that, yeah, epiphora. Have you watched the previous class? Or if you watched, you will find that due to trauma to the skin by the tissue, it might lead to eczema. So eczema, okay, and
Yes,
yeah.
ma'am.
Can you say it? Can you say this vicious circle?
Yes, ma'am. Epiphora that leads to eczema due to continuous wiping out, and that leads to more ectropion, and that leads to epiphora again, the vicious cycle.
So even if the primary etiology was involutional, there may be an added cicatricial component because of the eczema of the skin. And that's why we have to treat the skin as well in non-surgical treatment of ectropion. And we have to educate the patient and advise them to just soak and lightly or gently dry any tear. So the next photo here.
The queen.
Okay. Who is the queen of ophthalmology? Yeah. I'm the queen.
The cornea.
So the cornea. Excellent. So for this answer, I will give you 0.5. Okay. So in the future, I will tell you who is my king. So I have a king in ophthalmology and I have a queen. So the queen is cornea and the king is, I'm not going to disclose it right now. Okay, so remember, cornea is very important to be checked. It's like the queen bee. All other bees or workers are serving it, okay? Because this is a very precious structure and, you know, cornea is not forgiving. All right, and we have an issues regarding keratoplasty, starting from the availability of the donor and so on. So what is the mechanism of corneal damage in ectropion?
Mechanism of corneal injury.
Oh yeah, the cornea can be affected in ectropion. Why?
Yeah, yes, ma'am. I'm thinking. One is because of incomplete closure, there will be exposure.
Yes, the main mechanism is lag of thalamus, exposure
Lack of
keratopathy.
time.
Yeah. But if you compare it with entropion, what is the cause of corneal damage in entropion? Is the eyelashes.
It is
Okay.
eyelashes.
Okay. Again, you need to check for lag of thalamus regardless of the etiology of ectropion. So it's not only in paralytic, you have to check lag of thalamus in every case. And actually, if you remember in some old books, if we have corneal affection in paralytic ectropion, we give it a name, neuroparalytic keratitis. So, and again, don't confuse the two terms, neuroparalytic and neurotrophic keratitis. They are two different disorders. And here I wrote down all points to be checked in corneas, testing for lag of thalamus, bills, sensation, tear film, and staining under slit lamp. Please do your own work and try to think about the causes of lag of thalamus in general. Ectropion or paralytic ectropion is not the only cause for lag of thalamus. We have other causes. Can you mention another cause for lag of thalamus, for example, right now?
Ma'am, 7-nerve palsy will cause.
Other than facial nerve palsy. I said other than facial nerve. If I ask you what are the causes of lag of thalamus, one of the important causes is ectropion in general, especially paralytic due to facial nerve palsy. But we have other causes for lag of thalamus. Maybe you don't have such an answer in your study books, but you have to do your study notes, okay? So for example, if I say if we have a severe proptosis, is it one of the causes of lag of thalamus?
Yeah, yes, ma'am. Yes,
Yeah.
ma'am.
So
Yeah.
sometimes
Yeah.
the cause of lag of thalamus is not related to the eyelids. The eyelids are normal, like free, okay? But the problem in the globe is too big or like proptotic, and the eyelids can't close fully because of proptotic globe. And that's why check for lag of thalamus is one of the points to be assessed in proptosis checklist, okay? So you see this icon, you have to make your study note and summarize the causes of lag of thalamus. There is a kind of classification or categorization of the causes. Another photo, you are not lucky. There is a difficult question here. So can you relate? This is, I think, a movie or something. I have no idea, but it has this name. Centurion.
Centurion.
Yeah.
How I can correlate?
Yeah. Do you know the meaning of centurion? It's written in Kanishki, by the way. If someone is going to answer this question, I will give 2 marks.
So there is anterior malpositioning of the punctum, ma'am, in Centurion syndrome.
You got 2 marks. Okay, excellent. Thank you. So this is actually from Kanishki, our beloved book. There is a specific entity. We can say, if you see here from profile view, and if you remember, I said before, in Kanishki, you may find some photos in profile view because you can appreciate the sign better on profile view. You will find a small gap between the punctum and the globe. So the punctum here is the lower punctum. Generally speaking, we are talking about the lower punctum because this is the most important one. Is not opposed to the globe because of big nasal bridge. Kanishki doesn't provide us with a photo to appreciate how big the nose is, but anyhow, this is actually called Centurion syndrome, okay? Characterized by anterior malposition of the medial part of the lid with displacement of the puncta out of the lacus lacrimalis. It's not opposed to the globe, and it is a cause of epiphora as well. And this syndrome was mentioned in the chapter of lacrimal drainage system. Okay. By the way, linguistically speaking, centurion means an army during the Roman era. So maybe those patients look like the army officers during the Roman period. I don't know. Okay, let's move to another candidate. Can you relate? I'm giving you a clue because this is very difficult. I barely know the answer. This is a liquid, okay? And it is colored, it's yellow, okay? Maybe yellow to orange. And here is a description of this liquid, and it's used in manufacture of photographic plates and lacquers. So anyhow, can you relate this colored or this color to ectropion? Have you mentioned something related to something yellow or orange in ectropion?
I'm thinking,
So if you think about the skin could be yellow in jaundice, but jaundice has nothing to do with ectropion. But we mentioned in the previous class something that the skin has yellowish discoloration, and also it's a bit rough, tough. Okay, I'll tell you the name. This is the name of this liquid. Can you relate now?
Colloidin.
Mhm.
Yes, this is a congenital condition, colloidin. Just a minute. It has bilateral ectropion.
Is it congenital or acquired?
I think it's congenital.
Yeah, it's congenital. So what is the mechanism? Is it paralytic or mechanical or cicatricial?
I think it's cicatricial.
Yeah, cicatricial. So
Because
congenital,
yes,
so the congenital means the onset since birth or shortly after birth. And
right.
The mechanism here or the pathogenesis is cicatricial. Okay. And what is the scientific term? Because colloidin baby.
There is ichthyosis of the skin.
Excellent, excellent. So I'm giving you 1 mark.
Thank you.
I'm a bit biased toward ladies. Okay. Okay.
Thank you, madam.
They are answering, ma'am. No?
Yeah. I'm going to choose you. Don't worry.
Colloidin baby.
So ichthyosis. Okay.
Yes.
The following question is only for gentlemen. Okay.
Yes, sir.
So what's the meaning of miracle poison? Okay, let's tell you a story first while you are thinking. So this image, actually, it was created by ChatGPT. So I asked ChatGPT to create an image that shows a beautiful face, but without specifying the gender. Okay. And the ChatGPT provided me with this image. So this is the ideals of beauty in the eyes of ChatGPT. Okay. What I was doing, I was distracting you, Dr. Anne. So you have to answer the question right now. What's the meaning of miracle poison?
It's a botulinum toxin.
Excellent, excellent. I'm giving you 2 marks. So why it is called the miracle poison?
It is for treatment, for use in the treatment of certain conditions. Even if it is a poison, so it is in the therapeutic applications.
Okay, yeah, it's a good start. But if we are talking about something miraculous, we are here specifying special indication for Botox, okay?
Yeah.
Which is the most commonly used. What is the most common indication for Botox? It's not for ectropion or entropion.
Special aesthetics.
Yeah, aesthetics. So the most common indication for Botox to treat retids or so we have, this is another term for wrinkles or lines. So by the way, we don't say wrinkles in front of the patient. We use euphemistic language because wrinkles is a reminder of their aging. So we say lines or retids to get a smooth youth look appearance. All right. So tell me some of the complications of botulinum toxin. And said before, you have to say the medical term. Can you tell me some of the complications of Botox? So if the Botox here, or so I'm saying right now Botox because it's easier, but if there is excess amount or over response in the upper eyelid, it might result in what as a complication? Ptosis. And if it is leaked in the lower lid, it might result in what? Ectropion. So here are some of the complications. Ptosis, of course, we are talking about the upper lid, ectropion of the lower lid, maybe incomplete closure, lag of thalamus, and maybe it reaches the extraocular muscles and cause disturbance in the actions, so it may result in diplopia. So now imagine someone is seeking cosmesis because of wrinkles or because of lines, and they ended up with one of these complications. It was a catastrophe. And also, you may get this complication if Botox is used for other indication like essential blepharoplasm or hemifacial spasm. Okay. There is some irony regarding Botox. So, for example, here we said lag of thalamus. So just to make a correlation. So this is a way of learning or teaching to make a correlation. Here we said, and it might be confusing for others. So Botox can cause lag of thalamus, okay? But we inject it in the upper eyelid to protect the cornea, okay? Again. So here, lag of thalamus is one of the complications because of ectropion. So here, if we have severe ectropion because of Botox, it may result in lag of thalamus. But we use Botox in paralytic ectropion, okay, and injected in the upper eyelid to control the lag of thalamus and protect the cornea. So here this is a treatment, but here this is a complication, okay? Again, here, if you remember in Ectropion, we mentioned that one of the temporary measures to inject Botox in the spastic lower eyelid Ectropion. Okay, so here Botox is a treatment. Okay, so we use this Ectropion, this side effect to treat Ectropion. You got it?
Yes, ma'am.
And again, you know, Botox is one of the lines for treatment of strabismus. I mentioned only some of the indications for Botox and some of the complications, but as I said before, you have to prepare your study note regarding Botox, about the nature of the substance, contraindication, complications, and indications. So
Yes.
again, we have double-edged sword regarding Botox and paralytic ectropion. I'm summarizing the points again. So in the upper eyelid, we inject Botox as a temporary measure to address lag of thalamus to protect the cornea. On the other side, conversely, Botox, one of the iatrogenic causes of paralytic ectropion of the lower lid, of course. Okay, thank you, Dr. Let's move on to another participant. We have 3 photos here. My question is, what is the common theme? There is a common word or there is a common keyword in all of these photos.
Ectropion.
Yeah, exactly. I'm giving you 1 mark.
First one is the medial ectropion, punctal ectropion.
Exactly, sir.
Second one is the lower lid ectropion.
Mhm.
Third one is the ectropion UVA.
Okay. If you're giving this photo in the exam, if you say ectropion UV, it's good, but it's not enough because there are other important signs in this photo. So can you tell me the most important finding or findings in this photo apart from ectropion UV?
Hypochromic iris.
I know in Middle East and India and Pakistan, Bangladesh, and so on, we are not familiar with fair-complected people with grayish and greenish and bluish eyes, but this is actually not hypochromic, okay? It's just the color of their iris.
Is there neovascularization?
Yeah, exactly. And actually, the presence of ectropion is a clue because whenever we have neovascularization, what's the name of? There is another term for neovascularization of the iris. There is another term.
Neovascularization of the iris.
Yeah, it has a name.
Rubiosis iridis.
Okay, rubiosis. So because this abnormal blood vessels is associated with scarring. It's like you know, peripheral diabetic retinopathy. We have a scarring, and that's why there is traction retinal detachment. Again, here neovascularization is associated with scarring, and that's why this is the cause of ectropion. The ectropion UV is caused by this abnormal blood vessels. Okay, and you can see this eye is angry eye. It's a red eye because probably the IOP is very high.
Okay.
So in the exam, it's not enough to say ectropion. You have to notice the abnormal blood vessels. But there is some tip here or like a trick. In light-colored iris, we may notice the normal iris vessels because iris is a vascular tissue. All the uveal tissue is vascular, it's highly vascular. So how to discriminate between normal blood vasculature and abnormal? So the presence of ectropion here is a clue, okay? And also high IOP, all are supportive of your diagnosis of neovascular glaucoma or rubiosis iris, okay? Thank you so much. So we have a match. I'm trying to distract you by providing you a lot of photos, okay?
Okay.
But I didn't mean to challenge you. So there is no time here. There is no timer. So take your time and try to match. This is a single best answer. You may think that one can fit more than one photo. There is one answer for each photo.
A is uriblepharon.
Okay, excellent.
B is upper lid and lower lid retraction and possible proptosis.
Well done.
C is lower lid retraction.
Exactly, yeah.
D is lower lid ectropion.
Well done. So I'm giving you another 1 mark. So you got 2. I said here possible proptosis on the left side because you need to confirm it by Nafziger and Worms and by measurement, okay? But definitely there is upper lid retraction because whenever we have upper lid retraction, the tarsal show is not evident, it's very small. And usually upper lid retraction is associated with lower lid retraction in the setting of thyroid. And we have something called temporal flare here also. This is uroblepharon, which is ectropion of the lateral parts on both sides. This is a congenital abnormality. And in the lower 2 photos, actually, those 2 patients both have facial nerve palsy, lower motor neuron facial nerve palsy. But this patient has also ectropion. You can see part of the tarsal conjunctiva, and of course, you can appreciate the pooling of the tear of tear film. And when you check lag of thalamus, there is a little bit rim of the exposed globe, so we have some lag of thalamus. Here is another one of facial nerve palsy, okay? But here, according to the reference, it was written that the patient has only retraction. When we are going to discuss facial nerve palsy in neuro classes, it's not all about ectropion, but they may result only in retraction. So the lower lid is only retracted, okay? So the punctum is not ectropionized according to the reference because the image is not focused. There is a significant lag of thalamus here. There is positive bills, but it's not excellent because you still see part of the cornea. The aim of this photo quiz to show you that sometimes in facial nerve palsy, you may have only retraction. And if you remember the case of my colleague that was shown in video, actually my colleague mentioned that this patient has only retraction and doesn't have ectropion and doesn't have ectropion of the punctum even. So if I ask you what are the causes of lower eyelid retraction, you may say facial nerve palsy, you may say thyroid, if it is associated with upper lid retraction with or without proptosis, okay? So you can write now in your study note that you have to revise the causes of lower eyelid retraction alone, for example. So this is a text. My question is about who am I? I am one of the lower eyelid surgeries. Okay. The first surgical steps are lateral canthotomy and inferior cantholisis. I address horizontal lid laxity that might be associated with ectropion or entropion. Who am I?
Lateral tarsal strip, no?
Because it's easy, I'm giving you half a mark. Okay, so yeah, this is from the American Academy. And this maneuver where the lower eyelid is pulled upward in order to show the patient the effect of the surgery. What could be the effect of surgery of the lateral tarsal strip? Actually, by only observing the photo, you can appreciate the steps or the principle of the surgery. Okay, but generally, you don't ask about the steps or the details of the surgery, but by just looking at the photo, you can appreciate that part of the tarsus is fashioned and sutured to the lateral orbital rim. And that's why it's called tarsal strip. We are making strip, and you have to make it tight. It's called the lateral tarsal strip because all the maneuver are placed laterally on the lateral part.
The case had the diagnosis of 2 gap, lower lid cicatricial ectropion, and treated with 2 gap. treated with skin graft. Two gaps are there.
Yes.
I don't know the other graph.
Taken from?
Taking from post-auricular or supraclavicular. I don't know from where.
No, you can know. Just look carefully at the photo and you will see the donor side.
Then it is, I think, supraclavicular, ma'am. I don't know.
Please look carefully at the photo. Why you said skin graft? Because this is skin graft, right?
Yes, ma'am.
Is this area is the only operated area in front of your eyes?
I can't see other area, ma'am.
No. Okay.
Oh, yeah. Sorry, ma'am.
Okay.
I can see the upper eyelid. Oh my God.
Okay, so
Yeah.
refine again your answer.
Yeah. Two area. Okay, fine. Lower lid cicatricial ectropion treated with skin. What do I say? Skin flap.
Flap?
Oh,
What is the flap? So flap, there must be a connection here. In flap, there must be a continuity. Okay, so if you have okay, so it's a graft. So don't correct one mistake by making another mistake. So this is a graft, okay? Because flap should be connected with the donor side.
Okay, ma'am. Okay, ma'am. So treated with skin graft. Can I say skin graft?
Yes, because it is like it's like a segment here. It's a full segment here. This is skin graft.
Skin graft taken from upper eyelid.
Excellent. So I'm giving you 1 mark. All right. So this called distracted. You've been distracted by the lower part, and you turn a blind eye to the upper part, despite the fact that it's very obvious.
Really, ma'am?
Yeah.
I focused on that and
yeah. It happens. Okay. And imagine the stress of the exam or the exam stress, another things happen also. So that's why we need to practice. So let's see. You said left side lower lid, I guess. You mentioned the side, and you have to mention the side and whether it's upper or lower. And you said also cicatricial. And you see here, the case had, because right now there is no cicatricial element, but the patient had. Okay. You missed one answer here, because I said before in the previous class, we remove the scar tissue because definitely there is a scar tissue here. So the first principle is to remove the scar. And then we have a skin graft, and it's taken from the upper lid. This is the full answer. But we have another additional point. I will give 2 marks for someone who will say it. There's another sign in this photo. Or let's say I'm suspected because the details of surgery wasn't mentioned in this book. But I guessed that there is another surgery. There is another step in the surgery that was done in this patient. So can one look carefully again at the photo and try to find additional sign? I will enlarge it here.
There is a lid shortening also.
Okay, thank you, Dusma. I'll give you 2 marks. It will compensate for your previous one, so you got 3 marks right now. So you see this one? This patient may underwent a lid shortening surgery, like pentagon excision. All right. The next one. Can you tell the difference?
I'll describe picture B first because that is clearer to me. There is the left-sided or lag of thalamus, and there is paralytic ectropion of the lower lid, most likely due to left lower motor neuron facial palsy.
Okay, so, I can't see for sure the ectropion, but the most obvious one is you have to mention the obvious. Yeah, you may say I suspect the presence of ectropion or retraction. I need to examine the patient closely, and also I need to ask the patient to look at the primary position, because this patient right now was instructed to close their eyes. So in order to comment on ectropion or other things, you have to look at the patient at the without any instruction. Okay,
Right.
but you
Right.
missed. You have to comment on the bells, okay, because you
Yes, and
can.
there is poor Bell's phenomena on the side.
Yeah, part of the cornea is visible. You have to comment on the nasolabial fold here. It's absent.
Sorry, nasolabial fold. Yes, that is
Okay.
absent also.
So the left side actually is fully affected by the lower facial neuron lesion,
Yes.
facial nerve palsy.
Yes.
Okay.
Yes.
How about the other one?
Okay. So picture A, according to the picture, I suspect a right hemifacial spasm, most likely.
Yeah, exactly.
The patient.
Okay. So
Yes.
this is a tricky question because in this photo, the patient wasn't instructed to close their eyes. There's no any
Yes.
instruction. This is like
Yes.
the usual appearance, the natural
Right.
appearance, the natural appearance. But here the patient is instructed to close their eyes. Okay.
Yes.
So
Yes.
I'm giving you 2 marks.
Thank you.
One is hemifacial spasm, and the other one is lower motor no facial nerve palsy.
Yes. Thank you.
Excellent, excellent. Can you tell the difference? Let's start with B. Do you think the patient is instructed to do something, or this is their natural appearance? This patient
I think instructed to show the teeth
and raise their eyebrows. This patient was giving 2 instructions, okay, to raise their eyebrows, I guess, and to show their teeth. Okay, so what are the findings?
The left-sided mouth is deviated. That's working, but the right side is not working.
Yeah. So in
So it might be
we call it the angle of the mouth is deviated towards the healthy side.
in this side. Yeah. So it is the other part of the face. Yeah, there is loss of forehead crease.
Okay,
And
so
there
we have lots of wrinkles here. We have affection of the upper forehead and the lower. So what is your diagnosis?
my diagnosis is right-sided element facial nerve palsy.
Please don't say abbreviation. Please say lower motor.
Lower right-sided lower motor neuron facial nerve palsy.
Oh, okay. So I know you are new generations are familiar with abbreviations, but generally it's advised to not say abbreviation in the exam. So sometimes we accustomed in many texts when they giving you a photo of lower facial nerve, usually they giving you a photo like this. The patient is instructed to close their eyes, but this is a practice to see a patient without this instruction. Here, the patient is not instructed to close their eyes. Okay,
Yes,
yeah, he was given another instruction. So even without checking the orbicularis, because this patient, you can't comment on the orbicularis because here the patient is not asked to close their eyes. But since the frontalis is affected,
and ma'am, little bit browdosis is there.
yeah,
And nasolabial fault is
yeah, because this is one of the signs of lower motor neuron facial nerve palsy. We have affection of the frontalis, which is the elevator of the eyebrow. So we have drooping of the eyebrow. Excellent, well done.
However, it's more accurate to say inability to raise the right eyebrow, because here we assume that this patient is instructed to raise his eyebrows. So instead of saying drooping of the right eyebrow, say inability to raise the right eyebrow. Again, in order to comment on the position of the eyebrow, like drooping or not, we have to see the patient looking at the primary position without any instruction.
How about the other photo?
In the other photo, the left side, patient is asked to close the eye, I think. Yeah. So there is right side closes properly, and there is deviation of angle of mount in the right side, but in the left side, eye closure is not that strong, and mouth is not. That means there is no marked. What I say, angle is not deviated.
Okay, so you can say absence nasolabial fold and movement of the angle of
Yes,
the mouth.
absence
So it's
nasolabial
affection
fold.
of So there is affection of the lower part of the face. And in this photo, the patient is instructed to raise their eyebrows.
Yes. Patient can raise
Their
is it
eyebrows.
properly?
Yeah, so they are almost at the same level. So the upper
Yes,
part
yes.
of the face
Raise is okay.
is relatively okay. So what
and
is
the
your
lower part of face has been involved.
okay? So what is your
So
diagnosis?
my diagnosis right sided upper motor neuron facial nerve palsy.
Exactly. So I brought this image how to differentiate between both. So this is actually an upper motor and this is lower motor on the right side, and here
It's a
on
right
the
right side.
yeah, right side. Yeah, because
Opposite side will be affected in upper motor neuron palsy.
yeah, opposite side. But if you notice here, there is a slight affection of the orbicularis.
Yeah, ma'am. That's
Yeah,
not
the
that
closer,
strong.
yeah, it's not that on the side, right side. And that's why in references, you will find that in upper motor, the upper face is relatively spared. You will find this keyword relatively.
Yes.
Okay. So can you explain this diagram? Because this is the neural basis. Why there is
Yes, ma'am.
yeah.
That we can see the middle part of the left side of the picture. I think it's divided into two part. The yeah.
We have
The
the nucleus
upper,
here. Yeah, we have the nucleus for facial nerve.
yes.
The upper part of the nucleus is responsible for the upper face, and the lower
Yes,
part of the nucleus is responsible for the lower face.
lower face. The
So
upper part of the nucleus is getting supplied from both sides,
yeah, okay. And the
but the
lower
lower
part,
part is receiving the supply from contralateral side.
so if I have a lesion here, it will affect
The opposite sided lower lower part.
And that's why in upper motor neuron lesion, we have affection of only the lower part of the face on the contralateral side. Okay?
Yes, ma'am. Yes, ma'am.
But in order for the upper part to be affected, the lesion should be, generally speaking, it should be from the nucleus and along the nerve on the ipsilateral side. Because it's very hard to get a lesion on both sides to affect the upper face. Okay?
Yes, ma'am.
Excellent. So I'm giving you 2 marks.
Thank you, ma'am. At last.
At last, yeah.
I can answer.
You feel energized now. You need more grades, more marks. It's an easy one, and it has only 0.5 mark. So true or false? So can you read aloud this?
Congenital ectropion and entropion involve the upper lid more frequently than lower lid. False.
So can you restate it like correctly?
Lower lid more than upper lid.
Yeah, exactly. So regardless of the etiology, the lower lid is more affected than the upper lid. The only exception is, this might be confusing for you. So the lower eyelid is more affected than the upper lid, regardless of the etiology. So whether ectropion or entropion. The only exception was in entropion. If the entropion is caused by trachoma,
yeah,
it will result in cicatricial entropion of the upper eyelid. Okay, I'm giving half mark. So this might be confusing. Actually, this was taken from a reference. So here the writer is intentionally inserted this word congenital in order to confuse you. You may have the knowledge that lower eyelid is more affected than the upper eyelid, but you didn't study congenital. So you may think, oh, maybe congenital is against the rule or an exception to the rule. But the truth is, even congenital, the lower lid is affected than the upper eyelid. The last one is optional, and it's for those who like linguistics. So if you are good at linguistics, I mean here English and maybe French, so you can raise your hand. Or let's make it optional. So I will show you the question, and the one who is quicker at saying the answer will get the mark. Okay? Let's make it optional. It's the last question, by the way. First, pronounce this word.
Laissez-faire.
Okay. And what's the meaning?
We'll leave the wound open so that it will heal by marsupialization.
Okay. This is the use of this term, laissez-faire, in ophthalmology. But actually, linguistically speaking, the meaning of laissez-faire is a French. It's very obvious that's French in origin.
No, it means to leave it alone.
Yeah, who's saying this? Okay. So I'm giving half mark, and I'm giving you 1 mark.
Thank you.
I'm very unfair, I know. Okay, so to leave it alone. So actually, linguistically speaking, it is a kind of policy or doctrine to give freedom. So, for example, the government give freedom to people to do whatever they want, okay, especially in the field of economics. All right, so it's a kind of practice or philosophy. It means absence of interference or absence of restriction or limitation. Give freedom of a choice and action. So here if we have a wound, huge wound, we leave it alone. We don't interfere. We keep it heal on its own self, okay? So actually, it's a nice paper about laissez-faire, how far can you go? And the majority of cases healed nicely. Only 2 out of 10 cases developed cicatricial ectropion, and this is one of the cases. So imagine this huge defect result in this small area. Of course, there's cicatricial ectropion, and it should be addressed later on. We have another word similar to, because they have the same ending, savoir-faire, and savoir-faire means, again, you can relate to it, means to have like polished sureness in social behavior. And this again, a reminder to be very respectful during the exam. Of course, not during the exam, but in general. But we are talking about the exam because we are now focusing on the exam and preparation for your exam. So you have to be very respectful, not only to the examiners, but also to the patients, other candidates, other personnel. And it's not all about what you are saying. So it's not enough to say, I will say thank you and I'm sorry if you did a mistake, but the way you say it, the tone of your voice, your body language, eye contact, okay? Being polished is not all about what you are saying, the words you are saying. You may say thank you, but in an angry tone or in a disrespectful tone. So you have to be careful, even if you did bad in the exam, you have to be respectful and you have to be patient and polite. Okay? At last, we came to the final part, the closing slides. I'm going to show you a table where I summarize some of the points contrasting entropion with ectropion, okay? Symptoms and history are points you have to work on your own as a kind of assignment. And you will find the MCQs at the end of this video. So this is a table. It looks complicated, but we are going to go over each point one by one. Okay, let's start. So, as you can see here, I also going to say the points of difference and some of the points of similarities. And I will show you how sometimes, even though entropion is just the opposite of ectropion, but still there are some points of similarities between both disorders. Starting with the definition. Quickly, we said before that entropion is what? Is inturning of the lid margin. Okay, so don't forget lid margin, eyelid margin. Ectropion is completely the opposite, outward, turning of the lid margin. But if you remember, we added some points in the definition because I want you to remember these points. So once we have entropion, we have secondary trichiasis, and eyelashes totally, collectively is responsible for the symptoms and the complications in entropion. While in ectropion, epiphora is an important symptom and sign as well because of malposition of the punctum in addition to other mechanisms we discussed before. As you can see, the differences between
both disorders. Could be any similarity regarding the definition? Yes. What is the similarity? Both are disorders belong to the eyelid margin. So both are disorders of eyelid margin misalignment. They are both eyelid margin misalignments. But here intern and here outer or eversion. Number 2, the etiology or pathogenesis. As you can see here, involutional is a cause in both involutional. We have involutional entropion and we have involutional ectropion. And laxity is a common pathogenesis in both, whether it's horizontal lid laxity, medial cancel tendon laxity, and lateral cancel tendon laxity. So that's why I wrote here 3 points under the heading of laxity. But we also said this insertion of lower eyelid detractors or dehiscence or lengthening. And we mentioned also spastic component could be also present. And here the asterisk here or the star, because sometimes we say laxity in the presence of poorly supported globe, like small globe, can result in involutional entropy. On the other hand, we have the 3 points under the laxity in involutional ectropion plus gravity, and we added also retractors dehiscence, and we added also well-supported globe, like large globe. Cicatricial etiology is present in both, but the level is different. So here we have cicatrization at the level of the posterior lamella. We mean here palpebral conjunctiva and sometimes tarsus, but in ectropion, the scarring is at the level of the skin, anterior lamella skin mainly. Here we have spastic components. We have sometimes spastic entropion alone, or maybe part of the involutional entropion. So we have here a spasm of the orbicularis, but here the opposite. So this is like, and that's why I wrote spastic and paralytic in red, because they are completely opposite to each other. Here we have paralysis of the orbicularis. Okay. Also, we have congenital causes for each entropion and ectropion. The next point is symptoms. We may have red eye because of cornea and conjunctival irritation, foreign body sensation, okay? And of course, these result in watery eye, result in lacrimation, over-secretion of the tear film, okay? But in ectropion, I added here chasmesis because it's significant and noticeable sign to see the palpebral conjunctiva. And under the watery eye, don't forget epiphora. So we have 2 mechanisms for watery eye in ectropion, lacrimation and epiphora. Here I inserted this asterisk because sometimes the ectropion is not visible. When we are talking about early ectropion, like medial ectropion involving only the punctum. So be careful, sometimes the ectropion, medial ectropion, like first grade, is easily overlooked. The next point in the table regarding secondary effects on structures like cornea, conjunctiva, eyelashes, sclera show, and punctum. So in entropion, we have secondary trichitis. As a result of entropion, there must be secondary trichitis, resulting in foreign body sensation, lacrimation, watery eye, and corneal ulcer. While in ectropion, we have epiphora and lacrimations, so both result in watery eye. We have secondary change in the punctum called secondary stenosis. We have keratinized conjunctiva. So by the way, keratinized conjunctiva is a problem because it acts like a foreign body. We have to treat this keratinized conjunctiva and take care of it. And because of severe ectropion or maybe paralytic ectropion, we may have corneal exposure because of lack of thalamus, especially if it is combined with poor Bell's phenomenon. And corneal exposure can result in ulcer, mainly inferior. Because we care very much about the cornea, so I dedicated 1 point to cornea. So the corneal damage in entropion is mainly because of the eyelashes, because of secondary trichitis. On the other side, it's exposure keratopathy we may expect in ectropion because of lack of thalamus. The vicious circle I mentioned in Ectropion is all about eyelashes. So we have Ectropion resulted in secondary trichiasis, causing corneal abrasions, ulcerations, and this may result in spastic component and more Ectropion and so on. And that's why I inserted here the infinity symbol, because this is a vicious circle, ongoing process. In order to cut this process, you need to correct the Ectropion and not the eyelashes. Here in Ectropion, it's all about the epiphora. So we have Ectropion result in epiphora, and this might lead to eczema, and eczema will add a cicatricial component because of affection of the skin and dermatitis, and this may also exaggerate the Ectropion, and we have another vicious circle. Regarding treatment, please don't forget the lines for temporary measure to protect the cornea. So in both, we have to protect the cornea, okay? There might be some similarities in the lines, but there are some differences. So be careful. So never say, for example, tarsorrhaphy, one of the temporary lines for Ectropion, in paralytic Ectropion, we may do lateral tarsorrhaphy or Botox injection of the upper eyelid in paralytic Ectropion, but we can't do this in Ectropion. Okay, so notice the difference in the lines, and remember, lateral tarsal strip is a common procedure. Sometimes we do it in Ectropion and Ectropion because simply it addresses horizontal lid laxity. So any surgery for horizontal lid laxity, like horizontal shortening procedure, can be performed in Ectropion or Ectropion. Here we are talking about the involution of Ectropion and Ectropion generally because it is as a result of horizontal lid laxity. In surgeries, we may use sutures. Generally speaking, the sutures in Ectropion is called everting sutures, while in Ectropion, the sutures are called inverting sutures. And regarding the technique, definitely it differs, okay? But we are going through the details, and I think they don't ask about the details on how to perform the inverting sutures or the everting sutures. How about the station? You may expect Ectropion in oculoplastic station, and maybe one of the signs in the anterior segment station, okay? On the other hand, Ectropion is mainly in the neurostation because of the paralytic Ectropion, so you may expect questions about facial nerve palsy, but you can expect it also in oculoplastics. The last point, as you can see, is empty, and I inserted this vector. It means that you can add more points according to your study. This table, not to study it or rehearse it or memorize it, I just wrote this table to allow you to think about that you need to reflect on what you are studying. So once you are confronted with disorders that they look similar or they are confusing or they are opposite to each other, you may in your mind making comparison or contrasting both disorders. It doesn't necessarily to be written, but at least in your mind. This process of reflection helps you memorize information, okay, and fossilize the ideas and help you avoid mistakenly say something belongs to disorder, another totally completely opposite disorder. I like this analogy. So sometimes they say that, this net, this is a net. This represents the eyelid, the lower eyelid. This net should be tight enough in order to be like perfectly doing its job properly. But if we have laxity, if we have like lax net here, it may be turned toward this side or the other side. And again, that's why in horizontal lid laxity, we may get Ectropion or Ectropion. And once we have significant eyelid laxity, you have to correct it. You should address it. And actually, I know this analogy from this wonderful lecture by Cyberside. So I do recommend all of you to watch this video, this lecture on YouTube, where the lecturer here is talking about both disorders, Ectropion and Ectropion, and she focuses on the surgical management. This is a very helpful, invaluable lecture. Please do watch it. I want to conclude by showing you this slide once again. Remember my classification of eyelid malpositions. I do like this way of classification. So we can classify it according to the eyelid level in general or the eyelid margin alignment. Under the heading of eyelid level, we have ptosis, and we cover this topic in 4 classes, and we have retraction that I'm going to address in neuro classes in detail. Under the heading of eyelid margin alignment, we have Ectropion, and we cover this topic in 2 classes. And we have also Ectropion, although I talked about Ectropion in 2 classes, but I'm going to readdress this topic again while discussing facial nerve palsy in neuro classes. Mainly, you get ptosis and Ectropion in oculoplastic station, but when it comes to retraction and Ectropion, you may confront it with these cases in neuro plus oculoplastic station.
We completed the Ectropion class. The next class will be the final class in oculoplastics, that targeting oculoplastic station, because we need to move to another station. So the next class will be about miscellaneous topics. And as usual, I like to end my presentation by a piece of advice. So it's very important to prepare for the exam. So try to start early, organize your notes, practice, 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 as we always say. Whenever you need help, get help from your colleagues and also support from your family and friends. And don't forget to take care of yourself. And hopefully by practice, you may have a lot of information inside your head, but by rehearsal and practice with your friends, your study partners, you can able to organize your thoughts, and you can provide the examiner with a well-organized professional answer, okay? Hopefully, in the end, you will go to the exam calm, cool, and collected. Thank you all for your patience and for your attention and your contribution today. I'm very impressed. And I think the winner, I think all of you are winners simply because you participated. So all who participated are winners in my eyes. And I
Thank you so
hope,
much, madam. Thank
yeah,
you.
you will. I feel you are not overwhelmed today, and you look like this happy guy.
Thank
All
you,
right.
ma'am.
This quiz was a different
Uh,
experience of lateral thinking.
Yeah, thank you. Thank you.
Thank you. Thank you.
Just one question, Dr. Ghada. Are we supposed to know the various sutures which are used in various surgeries?
No.
No.
So I checked the experiences. You just mentioned the name of the surgery. Okay.
Okay.
The only surgery that you need to know the steps by heart is DCR.
DCR. Okay.
Yeah, in oculoplastic station, DCR.
Right. Right.
Okay.
Thank you so much.
Thank you, ma'am.
You're welcome. Have a good day and see you soon, inshallah.
Thank you very much, ma'am.
Thank
Thank
you.
you.
You're welcome.
Have a good day, ma'am. Bye. Thank you.
Bye-bye.
What is the preferred treatment for cicatricial ectropion? Lateral tarsal strip plus repair of lower eyelid retractors. Lateral tarsal strip plus skin graft. Fascia lata suspension of the lower eyelid. Lateral tarsal strip plus medial spindle procedure. Cicatricial ectropion is due to a lack of vertical tissue length, usually of the anterior lamella. Placing a tarsal strip with skin graft addresses the vertical shortage. A medial spindle procedure is useful for punctal ectropion. Repair of the lower eyelid retractors can address entropion. Fascia lata could be used to suspend the lower eyelid but would not result in lasting correction as it does not address the lack of vertical tissue shortage. What is the most common complaint following successful correction of paralytic ectropion? Consecutive entropion. Prolonged chemosis. Persistent epiphora. Overelevation of the lateral canthal angle. Paralytic ectropion is commonly accompanied by failure of the lacrimal pump and epiphora. Successful correction of the eyelid malposition typically does not restore lacrimal pump function since the orbicularis does not regain normal tone. During patient evaluation, the ophthalmologist attempts to digitally elevate the margin of the lower eyelid to the superior corneal limbus with the eye in primary position. The inability to perform this maneuver suggests what diagnosis? Spastic ectropion. Involutional entropion. Involutional ectropion. Cicatricial ectropion. In cicatricial ectropion, there is a vertical shortage of the anterior lamella, preventing manual repositioning of the eyelid. Potential causes include thermal or chemical burns, mechanical or surgical trauma, tumor removal or blepharoplasty, chronic actinic sun damage, rosacea, atopic dermatitis, eczematous dermatitis, herpes zoster, and ichthyosis. In spastic and involutional entropion and involutional ectropion, one can return the eyelid to a normal position using digital traction. What procedure that is used to correct punctal ectropion involves a horizontal fusiform excision of conjunctiva and eyelid retractors 4 mm inferior to the puncta? Lateral tarsal strip. Punctoplasty. Medial spindle. Rotational suture repair. In cases of mild medial ectropion with punctal eversion, a medial spindle procedure can be performed. The procedure involves a horizontal fusiform excision of conjunctiva and eyelid retractors 4 mm inferior to the puncta, followed by inverting sutures for closure. In cases with associated horizontal eyelid laxity, lateral canthal tightening may be used in conjunction with this procedure. In the lateral tarsal strip procedure, the tarsus is sutured directly to the lateral orbital rim periosteum. The goal of this procedure is to correct the position of the eyelid while maintaining the horizontal dimension of the palpebral fissure and a sharp, correctly positioned lateral canthal angle. Punctoplasty changes the size of the puncta and does not alter the punctal position relative to the globe. Rotational suture techniques are used as temporizing measures for involutional entropion. However, when these techniques are used in isolation, recurrence is anticipated.